righty. I think I just go, right? All righty. Hi, everyone. My name's Hillary Wright. I am the Director of Nutrition for the Wellness Center at Boston IVF. And tonight we're going to be talking about PCOS and diet and lifestyle strategies to manage to optimize fertility and maintain good health for a lifetime. And I'm just going to start by sharing my screen. I have a few slides to just sort of provide some background on the topic and to clarify some points of confusion that I often see. All righty. All righty, and I need to get to the top here. All righty. So just a little bit about myself. I have been with the Wellness Center at Boston IVF since 2006, where I counsel patients with a variety of health conditions, mostly people experiencing fertility challenges. I also work part-time at the Dana-Farber Cancer Institute in Boston, where I take care of people going through cancer treatment and then those trying to live their healthiest life in survivorship mode after the fact. And so, you know, I have over 30 years of experience in nutrition education. And so is this nutrition specific to PCOS or general fertility too? It is a kind of put out there as a PCOS and fertility, but we can certainly, you know, talk about any aspect of fertility, even if it doesn't have a PCOS diagnosis attached to it. So I actually thought I would use these slides as a kind of an opener. I did a presentation for a national meeting about PCOS just before the pandemic, and I spoke to a lot of my patients, and I wanted to know what people with PCOS wanted healthcare professionals to know about them. And I just outlined some quotes here. So it's not just about fertility, it's about quality of life. For me, the doctor stopped acknowledging the problem when I had my babies. We know that PCOS is a diagnosis for a lifetime, but we'll talk more about that. It's often just associated with the reproductive years. The fact that we want our PCOS treated even if we aren't trying to conceive. Lean PCOS needs nutrition counseling too, not just a prescription for metformin and birth control pills. I find often women with lean PCOS are the most ignored because they don't present as what many clinicians, even particularly doctors and clinicians who are, don't see a lot of PCOS patients, may not even recognize it in these women if they don't present the way they typically think they do. So since losing weight can alleviate symptoms of PCOS, it would be nice to have the tools to do so, for sure. Also, not to tell women that PCOS means there's no chance to have a child. I can't think of anything more untrue or more psychologically harmful to say to a woman. I've had patients in my life tell me they were told as adolescents that they might not be able to have children. And in fact, women with PCOS are considered good responders to assisted reproduction. So not only is it mean, it's not true. I also want the option of traditional and natural approaches when treatment is presented. I'm 49 and the reproductive endocrinology practice is done with me since I'm going through menopause. I'd like to be looked at as more than just an overweight body. I've, you know, again, clearly very common in the population of people with PCOS is a lot of shame around weight and other aspects of self-care, a lot of assumptions made about the quality of somebody's diet, whether they're active or not, just simply based on body mass index. That I'm overweight because of PCOS, not because I don't eat right or exercise. And to truly listen, many times I feel doctors aren't hearing the full story and they've already categorized me based off my chart. I also need to occasionally excuse myself because I am getting over cold and may need to cough. So what is PCOS? To define the challenge, it's estimated to affect 6 to 18% or more of women, approximately 5 million women in the US, possibly more because we do know that many women with PCOS are undiagnosed. PCOS is responsible for about 80% of infertility related to not ovulating and about 30% of infertility in general. Kind of the classic hallmarks of PCOS are hyperandrogenism. So those are symptoms of high levels of testosterone or male hormone and chronic ovulatory problems. Estimates are that upwards of 70% of women with PCOS are insulin resistant, irrespective of weight, but higher BMIs are associated with more insulin resistance. But again, diet and physical activity helps regardless of what someone's BMI is. Most intimidating, though, is according to the CDC, or the Center for Disease Control, it's estimated that upwards of half or more of women with PCOS will develop prediabetes or type 2 diabetes by the age of 40. And I unfortunately do see a lot of women in my practice who are quite young and progressing on through prediabetes to diabetes, and we know that this is largely avoidable. I should say, and I should have said this at the outset, I authored a book on PCOS called the PCOS Diet Plan that outlines a lot of what we'll be talking about tonight. But I've also authored a book on diabetes prevention called the Prediabetes Diet Plan, which is also about insulin resistance. And most recently, a book on menopause called the Menopause Diet Plan that I co-authored with a friend from college. So I'm in a different phase of life from a lot of women, and they say, write about what you know. So that's what we did. So I just want to say right up front, I am not a physician. So I know that there were questions that were presented in the beginning, kind of pre-Facebook Live questions, and quite a few of them were about, were really questions that have to be directed to physicians. And so there's one here as well. Can you speak about prolactin levels and fertility? Mine are 30. I'm 38 years old and scared. I unfortunately can't answer questions about, hormone levels related to treatments. Those types of things need to be directed to a reproductive endocrinologist. And I know that Boston IVF has those clinicians on these events as well. So they're great questions. I just like to stay in my lane and not try to give advice around things that is really not my training. So I also wanted to say right up front that PCOS, or polycystic ovary syndrome, is a poorly named condition, and that it's named after a symptom, not a cause. And it's actually a symptom that you don't even have to be diagnosed with PCOS. So there is a movement afoot to try to change the name to something that's more reflective of what this condition is, which is more of a metabolic condition, meaning a hormone imbalance condition that carries additional health risks, not just during the reproductive years, but for a lifetime. So we already talked about the prediabetes and the diabetes. Infertility, most people are aware. Anyone who enters a pregnancy already with insulin resistance or at risk of insulin resistance will be higher risk for a gestational diabetes diagnosis during pregnancy, as well as potentially other pregnancy complications. PCOS carries an increased risk of cardiovascular disease, heart disease, hypertension, high cholesterol levels, higher risk of stroke, sleep apnea, non-alcoholic fatty liver disease, which is something that, from my perspective, doesn't get discussed enough. Non-alcoholic fatty liver disease is very common in anyone with insulin resistance, and so women with PCOS fall in that bucket, and it's an important thing for us to pay attention to, because we know that non-alcoholic fatty liver disease can be reversed and prevented. And then depression, anxiety, eating disorders for a multitude of reasons related to constant exposure to the threat of infertility and other health risks. Women with PCOS who struggle with their weight often experience, as I mentioned before, a lot of kind of fat shaming, a lot of skepticism among healthcare professionals that they're actually trying to lose weight. And all of that pressure and that kind of assault on body image increases the risk of eating disorders. So people with PCOS do have a higher risk of disordered eating. So how is PCOS diagnosed? There's actually 3 organizations that have official definitions, the National Institutes of Health, the Rotterdam criteria, and the Androgen Excess Society. But they now all kind of agree that the consensus is a diagnosis of PCOS is predominantly an androgen excess-based problem that combines hyperandrogenism and ovarian dysfunction, which may appear as polycystic appearing ovaries or that kind of string of pearls. First, what is excluded are diagnoses that could be similar, like Cushing's syndrome, thyroid disorders, congenital adrenal hyperplasia, hyperprolactinemia. So the challenge or the difference between a disease and a syndrome is a disease is, in order to have the diagnosis, you have to have A, B, and C, or you don't have the diagnosis, whatever the criteria is. In syndromes, you rule out A, B, and C, and then you look at what's left in the bucket, and in the eye of a knowledgeable clinician around PCOS, a diagnosis can be made. There are some women who will not become aware of this condition until they're in the postmenopausal phase, and it is believed that you can make the diagnosis of PCOS based on what their symptoms were around their menstrual regularity and any other symptoms of hyperandrogenism during the reproductive years. So another thing that is quite confusing is that we know that there are actually several different phenotypes of PCOS. So a lot of people are used to thinking of kind of the classic PCOS, which involves weight struggles and significant hyperandrogenism, some other things, and then the lean version. But there are actually acknowledged 4 different phenotypes. So the ones that are more considered classic are phenotype A and B. A, where there's an ovulatory problem, signs of hyperandrogenism, and that string of pearls, polycystic appearing ovaries. Classic B is ovulatory problems and hyperandrogenism without polycystic appearing ovaries. This kind of PCOS presentation, A and B, tends to have more pronounced menstrual dysfunction, increased insulin levels, more insulin resistance, and risk of metabolic syndrome, which is acknowledged as raising the risk of developing diabetes and heart disease side effects, and a higher prevalence of obesity. In phenotype C, this is considered ovulatory PCOS, where you may have hyperandrogenism and polycystic appearing ovaries, but regular ovulation. This phenotype tends to have intermediate levels of androgens, insulin, atherogenic lipids, hirsutism scores, prevalence of metabolic syndrome. So it's sort of in the middle. Excuse me. And then this hyperandrogenetic PCOS, where there's an ovulatory disorder, polycystic appearing ovaries, but no signs of hyperandrogenism. And in this case, we may often call this the lean PCOS, mildest degree of endocrine and metabolic dysfunction, lowest prevalence of metabolic syndrome as compared to healthy controls. So the reason why I just wanted to mention this is because women who are being diagnosed with PCOS actually come in all shapes and sizes and can have a variety of symptoms, which is why it's so important to have knowledgeable clinicians like the doctors and nurses at Boston IVF to take a look at your clinical picture and see, based on what they see in the bucket, does someone classify as having PCOS? So I'm a nutritionist. I'm a registered dietitian. In terms of my background, I have an undergrad degree in nutrition, a master's degree in health education. All registered dietitians have to do a year-long clinical internship, pass a board exam, and then get 75 continuing education credits every 5 years. So when someone is seeking assistance from Many of us go by the term nutritionist. Many people can call themselves a nutritionist without any formal training. So I am a registered dietitian, and so we have to go through many years of training and supervision in order to study the science of nutrition and provide advice. This can be sometimes confusing to people because this term nutritionist can be used fairly loosely. So I should probably say the role of the registered dietitian is to clarify the role of diet and lifestyle in managing insulin resistance, because that's what's going on behind the curtain. And, at least 70% of women with PCOS, maybe provide weight management, counseling, and support, management of diabetes and cardiovascular risks, including gestational diabetes. One of the gifts of the pandemic is telemedicine. So since I've been able to do telemedicine support to my clients, once they conceive and are pregnant, I've had much more ability to stay connected and follow my patients through delivery, which has really been a gift, because that helps to give my patients this kind of support that they feel like they need to manage the risk of diabetes and any concerns they might have about gaining too much weight during pregnancy. So that is one of those silver lining things. I know there's not a lot of them, but that's one of them. We do deal with a lot of lifestyle counseling and support. As I said before, disordered eating is not unusual. In fact, 80% of women with PCOS report binge eating. This doesn't necessarily mean 80% have binge eating disorder, but many women with PCOS report constantly craving carbohydrates, never feeling full, and this is a side effect of the insulin resistance. Not surprisingly, hits to self-esteem, loss of feminine identity, often a lot of weight loss baggage. I never put people on diets. I teach people how to eat healthfully in a way that will be supportive of their nutrition, good to continue to follow through pregnancy, and then for the rest of your life. And I do do a lot of fertility nutrition counseling, both in women with PCOS and those without. So what exactly are we trying to influence with diet and lifestyle when it comes to PCOS? So I like to think of our endocrine system. So these are all the different hormone systems in our body, like planets in a solar system that are constantly orbiting around each other and assisting each other, but sometimes they can collide. So those major endocrine systems are reproductive endocrinology. In women, this is the hypothalamic pituitary ovarian axis, blood sugar regulation, adrenal glands, those sit on top of our kidneys. Those are the endocrine organs responsible for our stress response, our thyroid. There are hormones that affect our gut, hormones that affect our brain, and these things all are always kind of intertwined and supporting and interacting, but sometimes, as I said, they can collide. So this condition that we call PCOS, which, by the way, originally it was called bearded lady syndrome 100 years ago, then eventually became known as Stein-Leventhal syndrome after two doctors that started to put together the symptoms. But it's only been since like the 1990s that we've started to refer to this as PCOS and acknowledge the important role of managing insulin resistance in reducing the long-term risks of PCOS and supporting fertility. So if we just look at reproductive endocrinology in women for starters, it all basically starts with, women, excuse me. Women are born with about 3 million eggs or so in our ovaries, and they basically sort of sit there dormant until puberty, at which point the hypothalamus and the pituitary, which are both in the head, start to communicate with the ovaries in kind of a cyclical, rolling, month-to-month way, stimulating hormone communication that every month triggers a clump of these eggs to jump into follicles, start to experience these hormonal influences over a period of 2 to 3 months, in the hopes that 2 to 3 months down the road, at least one of these eggs will complete the cycle, be in a follicle that's ripe and ready to be ovulated out, genetically healthy egg that hopefully can meet up with a genetically healthy sperm. They decide they're a good match, form an embryo, travel down a fallopian tube that's not blocked with endometriosis or scar tissue or what have you, and then land in the lining of your uterus where the uterine lining is thick enough for an embryo to implant. So when we think of the potential role of diet and lifestyle on this, it is to nurture genetically healthy egg and sperm development. So even though tonight we're primarily talking about women, the same diet and lifestyle strategies that we think support fertility in women also support fertility in men. That is actually more plant-based eating. Doesn't mean you have to be a vegetarian at all. It just means eating more fruits and vegetables. At least half of our grains is whole grains, more nuts and seeds and legumes and plant proteins, less red meat, more seafood, moderate amounts of poultry, dairy. All of those things have a role to play. So it's not all or nothing, but we know that the same factors in the body that can affect the genetics of any cell in our body can affect the genetics in eggs and sperm. So those are kind of loosely described as conditions that foster inflammation, oxidation, and toxic exposure. So with diet and lifestyle, we can kind of try to protect and defend the genetics in these eggs. This is, especially important during that 2 to 3 month period of time that we call the preconception period, where these eggs and sperm are being exposed to a lot of growth and change, and we want to kind of protect those and nurture the genetic material in those cells. So that's egg quality. What can we do there? But in terms of PCOS, there is a potential egg quality issue. But from an insulin resistance standpoint, if the hypothalamus and the pituitary and the ovaries need to continuously in a rolling manner, month to month to month to month until menopause, then any other hormone imbalance in the body has the ability to throw a wrench into this communication. So insulin is the most abundant hormone in the body. If someone has insulin resistance, they will have higher than perfect circulating levels of insulin. How much extra insulin depends upon how insulin resistant are they. So the strategies we know, based on research on diabetes prevention trials, that diet and lifestyle is the primary way to manage insulin resistance. There's a large, very well-respected clinical trial called the Diabetes Prevention Trial, or the DPP, Diabetes Prevention Program, where they took people with pre-diabetes and they either gave them basically no intervention, gave them a brochure, gave them metformin, which is a diabetes drug that is often used in women with PCOS during the fertility treatment phase, sometimes in addition to that, and then diet and lifestyle. And so they gave people these interventions, and 3 years later, they went back to see who had gone on to develop type 2 diabetes. And they found that the people who were basically brochured didn't lower their risk of developing diabetes at all. They went on to develop diabetes within 3 years at the rates that were expected as if they had no intervention. The metformin group was 31% less likely to develop diabetes 3 years later, but the diet and lifestyle group was 58% less likely. So we know that diet and lifestyle is the primary treatment for insulin resistance, whether it comes packaged as pre-diabetes, diabetes, PCOS, metabolic syndrome, non-alcoholic fatty liver disease. All of the diet and lifestyle strategies are the same. In the case of supporting fertility, it's to get insulin levels down so that hormone has less ability to interfere with these hormones. So if excess insulin and other factors, likely stuff we haven't even learned yet because this condition is understudied, much more so when I first started seeing women back in January of 2000, which is when I saw my first patient with PCOS. I didn't know what it was, and not a lot of people were talking about this at all. So relative to then, we know a lot more, but we still need a lot more research. But if excess insulin is noodling around with this hormone communication, if it's significant enough, it can throw a wrench in it all together. So a woman with PCOS is not having a period. Or it may noodle around with it enough just so that the periods are irregular. So what is the best diet therapy for PCOS? There's actually no consensus on this. because studies tend to be small, though they are getting bigger, they're improving. But in general, diet and lifestyle strategies that will help manage insulin resistance, to help regulate hormones, promote weight loss, to improve symptoms if indicated, enhance fertility, prevent diabetes. I do want to say that there is a lot of pressure on women with PCOS to lose weight. I know, I see it all the time. People refer to me for that all the time. And so I always tell people, I'm not here to boss you around and tell you what you need to do. I'm here to educate, as invited in to do so, and help you figure out what to throw against the wall that might help you feel like you're improving the quality of your diet and your lifestyle. But I strongly encourage people to try not to hook the healthy eating and exercise caboose to the weight loss train mostly, because it takes time to figure out what may actually help someone lose weight. And if we over rely on, is the scale moving, to make a determination whether the healthy eating and the exercise is worth it, then a lot of people get frustrated and they quit. And we know that no matter what your weight is, if you're eating healthfully and you're exercising, you're going to be more fertile, have lower risk of chronic disease, feel better in your body, no matter what your weight is. So I understand the pressure there, but I just want to advocate for diet and lifestyle is great for you on a lot of levels, no matter what. There have been a lot of higher protein, lower carb, low GI diets. Can be helpful, improve metabolic issues. I'm a believer in a moderate carbohydrate diet, not a low carbohydrate diet. I believe it encourages people to avoid too many healthy foods and is not sustainable. Eating a little more protein and fat can help satiate or satisfy people and help them feel fuller for longer. So, kind of pairing carbohydrates, healthful carbohydrates most of the time, those that are less processed, with protein and fat can be beneficial for maintaining muscle mass while losing weight, and helping people feel fuller longer. Insulin is some involved in protein metabolism, but much less than the influence of carbohydrates. But there is not research to support very high protein, very low carb diets, which in many instances may be high in animal fat and actually rebound by making people feel hungry all the time due to kind of dropping blood sugar levels from not consuming enough carbohydrates. And, I've been doing this for 37 years. I don't believe, people lose weight, for example, if you use that, is that a point? People lose weight as a result of what they're doing. If what they're doing can't be sustained, then it shouldn't be surprising to us that the lost weight is not sustained as well. So generally speaking, this is going to be the last slide. Diet and lifestyle strategies are the primary treatment for managing PCOS. Over-restrictive diets are not recommended and unsafe, often long-term. Many more benefits gained from focusing on positive steps of adding in healthy foods to the diet than taking foods away. So a lot of times in our culture, we tend to define what kind of an eater we are by the junk food we don't consume. In other words, a lot of people will say, I'm a healthy eater because I don't go to McDonald's, I don't drink soda, whatever. That's good, that may be true, but it doesn't mean that you are eating enough of the kinds of foods that bodies need to not just survive, but thrive. And in my experience, many people in this culture kind of practice along the edges of plant-based eating. Like they may eat some fruits, but not enough to really experience the health benefits. Some vegetables, but not the volume to really get the optimal benefits we know they bring to the diet. Experimenting with plant-based proteins, trying to get whole grains at least half of the time, adding nuts and nut butters and seeds, more poultry and seafood and plant-based proteins, less red meat. And then, of course, limiting added sugars, refined carbohydrates, and processed meats is advised, but nothing is forbidden in the absence of an allergy. So I never tell people, here's a list of foods, you can never eat them again unless they have bad allergy or maybe celiac disease and they really need to stay away from gluten. But, understanding why these recommendations are made is key to understanding how to manage PCOS. So that's the main reason why I wrote the PCOS diet plan, which is in its second edition. The first edition came out in 2010, is I think it makes a big difference to be actually guided through why diet and lifestyle matters, as opposed to just telling people, here's a bunch of rules and follow them. All righty, so I'm going to start going through these questions. And if anybody has any questions about what I just said, you can feel free to kind of throw that in. So I'm going to start at the top. Is there any one doctor at Boston IVF that helps people with PCOS? People get pregnant. All the doctors at Boston IVF are very knowledgeable in the management of PCOS. So any of them will be able to help a woman with PCOS get pregnant. What if hormone levels are normal but have ovulating issues where you don't ovulate without other symptoms besides irregular periods and light bleeding? So again, it's kind of more of a clinical question, better posed to a physician, because there's a lot of different hormone levels that they check. Women with PCOS, they tend to have hormone, they may have higher levels of testosterone, they may have higher levels of luteinizing hormone. So there's kind of a typical pattern that may present, but hormone tests are not considered part of the criteria because things vary. So it's kind of a general question, and I'm definitely giving a general answer, but that is something that is a really good reason to meet with a doctor at Boston IVF. Is it possible to get pregnant with PCOS? Absolutely. Absolutely. We know how to manage insulin resistance. In fact, when I first learned about PCOS, I thought, well, I don't really know what this is, but I do know how to manage insulin resistance because I've been taking care of people with diabetes, at that point for 20 years. So the good news is that the same things that you would do to improve the quality of your diet, more plant foods, less animal foods, more dietary fiber is hugely important. We can talk a little bit more about that. Less processed meat, less added sugar. So the same influences that we think as a rule are not great for overall health can trickle down to fertility, but that also means the same that also means that the same strategies that can lower risk of diabetes and lower your risk of heart disease and lower your risk of fatty liver are going to support and improve your fertility. I can't give answers to very specific clinical questions. My AMH is 4.88. Does that mean I have PCOS? All I can tell you is my understanding is that women with PCOS often have higher levels of anti-Müllerian hormone, but again, it's more of a doctor question than a dietitian question. All right. Thank you for doing this. We're just starting to try for a baby. I have PCOS that was just diagnosed. My partner and I wonder if we should go see a fertility doctor or do we have to wait? So that probably it's a good question to present to your GYN. So I know based on age, they tend to say if you're under 35, I think it is, it could take up to a year to conceive. If you're after that time, if someone is not conceived, then they should maybe seek out a fertility workup. If somebody's over 35, I think it is 6 months, or if somebody has any outlying risk factors for fertility. So I don't know that you have to wait, but I have to say I don't know enough about insurance coverage for these kinds of things as to whether you need to start with a regular GYN and then move on to fertility treatment. But if you have a GYN or primary care doctor, I would first talk with them and figure out when a good time for a referral is. PCS warrior. Hello. Will my chances of multiples be increased when I start Clomid on my next cycle? Again, sorry, doctor question. Women with PCOS may produce a lot of eggs, but my understanding is there may be issues with the quality of some of those. So I don't know enough about the statistics on PCOS, stem cycles using Clomid, and risk of multiples. So again, a reproductive endocrinologist could answer that. Is tofu and soy products bad for PCOS? No, actually, the research suggests they actually are good as a primary source of plant proteins. Tofu, soy milk, as well as any kind of legumes, quinoa, buckwheat, all of these things that are good sources of protein that come from plants are all considered very good for supporting fertility and for PCOS. So the assumption is if somebody eats more plant proteins, hopefully they're doing that by replacing, say, meat with more plant proteins. I can also tell you that the soy issue comes up a lot in my other job at Dana-Farber, where a lot of women who have had estrogen receptor positive breast cancer are told they can't eat soy because soy food contains estrogen. And I can tell you with surety, there have now been several large population studies, and women with estrogen receptor positive breast cancer, those that eat soy, they say do not do worse in terms of survivorship and may actually do better. So soy really gets slayed on the internet a lot, and there's actually not science to back that up. But there's lots of science backing up the benefits of eating more plant protein. So I eat soy all the time. I encourage people to do so. If you've never had tofu and you want to try it, I always tell people, go to like an Asian restaurant and have it made well before you start mucking around with it at home, trying to cook with it, so that you know what its potential is. But tofu doesn't taste like anything. Really, by itself, it takes on the flavor of what you consume it with. So yeah, I think it's a great idea. Are there any supplements you recommend to take during my first IVF cycle? Everybody who could become pregnant is advised by it's not the National Health Service, but one of the major government organizations in our country, recommends that any woman who could become pregnant at least take a multivitamin that contains folic acid, 400 micrograms. The reason for that is that assuring that you're getting 400 micrograms of folic acid in the very early days of pregnancy may reduce the risk of developing a baby with a neural tube defect, which is spina bifida or anencephaly, which is a baby born without a brain. The risk of that goes down 50 to 70% if you're getting this 400 micrograms of folic acid. You can easily get that from eating a lot of plant foods, but it's a good idea to just assure you're getting it, because the neural tube closes 22 days after conception. What can happen, particularly in women with PCOS who have irregular periods, it may be way beyond 22 days after conception before a woman realizes she's even pregnant. Because if you don't have regular periods and then you're working on your diet and lifestyle, increasing your activity, maybe losing a little bit of weight, and then you ovulate, but you didn't have a period prior to that, you could be pregnant and not know it. So the 400 micrograms of folic acid is considered the minimum amount. For people going through IVF, the amount in a prenatal vitamin or a preconception vitamin is recommended, which is higher. It's generally at least 800 micrograms, sometimes 1,000 micrograms, which is also called a milligram. So there are a variety of prenatal vitamins. They all contain extra doses of folic acid. The major difference between a preconception and a prenatal vitamin is the iron content. So, for example, there's a company called Theralogics that makes a preconception multivitamin called Theranatal Core that is basically a prenatal vitamin with extra vitamin D. Getting extra vitamin D during this kind of run up during the preconception and through the fertility treatment phase is also a good idea, particularly if someone has a history of low levels of vitamin D. But the Theranatal Core has 50 micrograms or 2,000 international units of vitamin D in it. All the other good stuff in a prenatal, including iodine, but only has a regular amount of iron, which is 18 milligrams. I do have concerns about women going through many, many months, possibly years of fertility treatment, And every day taking a prenatal vitamin that has 27 to 30 milligrams of iron. So you don't want to be iron deficient because that can affect fertility. But if you're not anemic, taking a prenatal or a preconception multivitamin with just that 18 milligrams of iron is fine. If someone has egg quality issues, there may be a role for coenzyme Q10. There may be a role for Ovasitol or Inositol, which is a B vitamin-like compound in the body that assists with insulin sensitivity. Taking inositol in the 40-to-1 ratio, 2,000 milligrams of Myo-inositol, 50 milligrams of D-chiro twice a day may assist with managing insulin resistance. So it's really, a good prenatal vitamin or a preconception vitamin, adequate amounts of vitamin D to make sure you're not deficient. So vitamin D deficiency can affect fertility, but being super vitamin D doesn't make you extra fertile. So it's really about individual needs. What is a low GI diet? So the glycemic index is a really interesting thing. It's an imperfect thing, but it's interesting. The glycemic index is the it's a measurement of the rate at which a certain amount of carbohydrate will show up in your blood an hour after eating. So things with a high GI tend to raise your blood sugar faster than things that have a low GI. As a rule, and I think that this is adequate for most people's interpretation, is the closer a carbohydrate comes to its natural form, in general, the lower the glycemic index. So, for example, eating whole fruit is going to have a lower GI than drinking juice. There's a lot of stuff that people can get into the weeds and get confused about glycemic index because a lot of times the research on this topic is used in a way that was not designed to be. So, for example, the way they determine the glycemic index of a variety of foods, and so this was couple decades ago anyway, some researchers were interested to find out how fast do certain carbohydrates get into your bloodstream after you eat them. So they took people without diabetes and they gave them 50 grams of carbohydrate of a variety of different carbohydrate containing foods in a fasting state. So like first thing in the morning, and then check their blood sugar an hour later. And what they're trying to do is measure that blood sugar rise up against things that have a GI of 100. Examples of that are that goop they have you drink if you have a glucose tolerance test. That is a GI of 100, and like white bread, like Wonder Bread. So, for example, 100, and they use 50 grams of carbohydrates, so uniform amounts of carbohydrates of different foods, which right there makes things a little screwy because, yes, you can easily get 50 grams of carbohydrate if you eat a bagel. An average bagel is about 50 grams of carbohydrate. To get 50 grams of carbohydrate worth of rice, you can, it's about a whole, a third of a cup of cooked rice is a serving. So 50 grams is a whole cup of cooked rice. Carrots, in order to get 50 grams of carbohydrate worth of carrots, you have to eat 1.5 pounds. People don't eat like that. So, but if we take the example of brown rice raises your blood sugar 55% as fast as Wonder Bread, therefore it has a GI of 55. The problem with carrots is carrots get taken in this 50-gram carb dose have a higher GI. The thing is, people don't eat carrots like that. People don't eat 1.5 pounds at a time. When you eat foods, carbohydrates of any kind, with other foods like proteins and fats, you immediately change the GI. So there's a lot of nuance. I do talk about this in my PCOS book. But the bottom line is the closer you can eat a carbohydrate to its natural form, the more effort your body is going to have to take to digest down that carbohydrate, release it into your blood as glucose, and retaining the presence of dietary fiber, which is a type of carbohydrate that human beings can't digest because we're not ruminants. We don't have 4 stomachs like cows and goats. When we eat dietary fiber, our digestion has to contend with it, kind of sift through it to untangle the glucose and the other nutrients so they raise your blood levels a lot slower. Fiber stays behind, and we now understand the critically important role of dietary fiber in feeding the healthy microbes that are in our gut that we call our microbiome. They're made up of probiotics. These probiotics eat prebiotics, which is probiotic food, which is dietary fiber, and produce as a byproduct of that countless combinations of compounds that act as antioxidants, anti-inflammatories, help your body to detoxify, lower your risk of diabetes, heart disease, cancer, dementia. Keeping our gut health in tip-top shape is super important for disease risk reduction. That requires fiber. The average person is advised to eat at least 25 grams of fiber a day. Studies tell us the average American is eating about 11 or 12 grams. Okay, would you mind talking about the effects of caffeine and alcohol in PCOS? So there's not, caffeine and alcohol have been studied as to their effects on fertility. Alcohol in moderation doesn't seem to be, unless there's somebody with a specific indication, is not specifically contraindicated during the reproductive years, but if somebody is actively trying to conceive, it's a good idea to limit your alcohol consumption. Caffeine, they've also looked at, because alcohol in higher amounts absolutely can affect IVF outcomes and fertility in general in both men and women. Caffeine does not appear to affect fertility. What it may have an effect on is miscarriage rate. So once somebody is trying to conceive, you kind of in that preconception mode, it's a good idea to limit or avoid alcohol and limit your caffeine to the amount that the March of Dimes recommends for pregnancy, which is less than 200 milligrams a day. Do keep in mind that these really strong coffees that a lot of us like tend to be higher in caffeine. So for example, a tall Starbucks, which is pretty strong coffee, which is the tall is the smaller one, I think has about 330 milligrams of caffeine, whereas like a Dunkin' Donuts medium, I think is under 200. Do we have a rough percentage on how many women in their early 30s with PCOS are able to get pregnant? I'm sorry, I can't answer that. There's so many variables that I don't even know if a percentage like that exists. Having said that, assisted reproduction is loaded with statistics. And if you meet with one of the docs, they can certainly give you a lot of data on why they make certain recommendations and the percentage likelihood of benefit. Does PCOS also impact the ability to carry a pregnancy to term? I believe that women with PCOS may have slightly higher rates of miscarriage, but I wouldn't want to fully own that answer. I believe that's the case, but certainly taking steps to improve their diet and lifestyle quality prior to conception and then continuing those on through pregnancy is the best anyone can do in order to carry a baby to term. What are the best types of plant protein? So there's soy. There are legumes, any kind of legumes, beans, kidney beans, lentils, chickpeas, black-eyed peas, soybeans, edamame. Quinoa is a plant protein. Buckwheat is a plant protein. Nuts and seeds. Hummus is made out of chickpeas. Also, if you count macros, what percent should be carbs? So from my perspective, I don't like low carb diets because I think they kick out way too many healthy foods. A moderate carbohydrate diet, from my perspective, is around 45% carbohydrates, plus or minus a little. So I'm a big fan of ranges. I don't like to kind of hog tie people to specific numbers too much. But sometimes, particularly if people are logging with nutrition logging platforms and such, they'll get data output that will tell them percent of calories from carbohydrates. I will tell you that the percentage of calories from carbohydrates is one thing. What really matters is how much carbohydrate you're eating at once over the day, because it's the amount of carbohydrate consumed right now that's going to dictate how high your blood sugar and therefore insulin requirements are going to be an hour from now. So it's carbohydrate quality. I talk a lot about this in my book. It's the 2 Qs. Quality, where is it coming from? Is it a whole foods-based carbohydrates, or is it ultra-processed food? And then the quantity, how much? If somebody eats a bag of chips and a Coke, they're going to have a lot of carbohydrate to contend with in the hours after they eat. If someone has a sandwich on whole grain bread and some fruit and a seltzer, they're going to have a fraction of that. So in the end, quantity is the biggest predictor of how much insulin you'll secrete. What about dairy? I like cheese a lot and definitely have PCOS with high testosterone and ovulation. How much am I limit dairy intake? The only situation where somebody, so first of all, there's this weird research that has been reproduced through the Harvard School of Public Health on dairy and fertility, and finds that as little as 1 serving of full-fat dairy a day seems to associate with better fertility outcomes. The more full-fat dairy you eat, though, the lower the response. So if people read that full-fat dairy thing, my advice is to limit it to 1 serving a day, and otherwise, think about maybe 1% milk, kind of middle of the road. The thing about cheese is actually a probiotic food. So when you take milk and you put cultures in it, you let it sit and age and become cheese, the cultures make the cheese, but the cultures are the probiotics. So they say any cheese that if you left in your refrigerator for too long would get moldy, tells you that there's microbes in there. It's probiotics. Cheese can also be a really beneficial source of protein for many people's diets. A lot of people like it. Like everything else, calories count. So, an ounce of cheese at 110 calories per ounce, depending upon what your goals are, people just need to be aware of where our calories are coming from and factor that all in. But there is one of the potential side effects of PCOS is cystic acne. And some limited research that staying away from mostly milk as opposed to dairy, cheese and yogurt, again, lots of health benefits as probiotic foods. But there's some evidence with acne research, so this is not just specific to PCOS, that taking dairy away for 2 to 6 weeks and see if your cystic acne gets better may be worth it. But outside of that, there is no across the board. Again, dairy gets picked on like soy does online. And there is room for all kinds of foods in the diet. If someone is a concern, they can always practice moderation. What's moderation? I don't know, 2 servings a day. Any dietary tips for reducing symptoms of hirsutism? The hirsutism is at least in part related to the insulin resistance piece. So when the cells that line the follicles that eggs mature in our ovaries, those cells are called theca cells. When they're exposed to too much insulin, they produce testosterone. So taking, kind of a comprehensive diet and lifestyle, how do you lower insulin levels? Mindful of your carbohydrates, spread them out over the day. Physical activity is the most natural way of improving insulin resistance and naturally lowering insulin levels. So there's a lot of synergy between the quality of the food, the dietary pattern, levels of physical activity. Ideally, we would be getting at least 30 minutes of physical activity, cardio type activities daily, but also at least 2 to 3 episodes of strength training, because flexing muscles pull glucose out of your blood without even needing insulin. When in the insulin sensitivity equation, insulin is only supposed to have to unlock our cells after meals. And then there are supposed to be these proteins in our cells called glucose transporters that pick up the ball and actually clear the glucose from the blood. And those are produced as a result of physical activity. So taking a very close look at physical activity levels is very important part of managing PCOS. I'm going to do egg preservation. I want to eat healthy to change my quality of eggs. How long does it take for the diet to be effective and has positive impact on quality of egg quality? So again, if you think about that preconception period, as soon as you start eating healthfully, things are going to start to improve in the body. that preconception period from when the eggs kind of hop into follicles and go through all those hormonal stimulation phase to the point of getting to ovulation, is 2 to 3 months. So that period of time is especially important. But we carry our eggs with us for life. So the sooner we get on, kind of more of an anti-inflammatory plant-based diet, lower in red and processed meats, lower in added sugars, the better. As someone with body dysmorphia, what would you recommend to sustain nutrition during pregnancy? That is a really, it sounds like a simple question, but it's not a simple question. Maybe a meeting with a dietitian would be a good idea, because eating healthfully through pregnancy is super important. There's no do-overs when it comes to making babies. So if someone's body dysmorphia is preventing them from eating enough out of concern for how pregnancy may change their body, I don't know if that's part of what you're asking, but body dysmorphia is definitely a psychological condition that needs that type of support. So hopefully you're getting some support around that to relieve some of that burden. I appear to have classic B phenotype. I don't believe I have insulin resistance. I know that food and exercise are important factors in PCOS. Are the strategies to help classic? So the thing I want to say about insulin resistance is insulin resistance, the tests that we use for insulin resistance tell us if somebody has been insulin resistant long enough that it's starting to affect their blood sugar levels. So everybody with type 2 diabetes prior to that had pre-diabetes. Blood sugar's bumping up, but not high enough to call diabetes. But everybody with pre-diabetes prior to that had pre-diabetes, where they had insulin resistance, but there's no easy test for it. Because the glucose, the fasting glucose testing, the hemoglobin A1C, those tests only tell us if somebody has been insulin resistant long enough that it's starting to affect their pancreas's ability to make insulin. So in that pre phase, we have to go on risk factors, and having PCOS is one of those risk factors. So there aren't also, from my perspective, different diet and lifestyle strategies based on phenotype, because as I said, it's a healthy way to eat for life. And so anything that someone would do to manage insulin resistance would also be good for egg quality and all of that. I think Myo-inositol is awesome. I think I particularly like an inositol supplement called Ovasitol by Theralogics. It's a powder that comes in this 40-to-1 ratio of 40-to-1 myo to D-inositol, which is the ratio of these two forms of inositol as they occur in the body. This really bumps up that dose. Comes in a powder that's pretty tasteless that you just mix in with water. And I would advise people to take it twice a day. It's a substance that helps to sensitize cells to the action of insulin. And my understanding is through a different mechanism than metformin. So sometimes people will take both metformin and inositol. These compounds have been studied neck and neck, and some studies have found that inositol is as good as, if not better than metformin. So I think it's got a lot of evidence to it, and I do recommend it a lot. Are patients seeing good effect from weight loss injectables along with lifestyle modification? I'm just, honestly, just starting to see more volume of people. And so I don't feel like I've seen them enough people long-term to really answer that clearly. I know that you can't be on these medications and get IVF. I know that a lot of women with PCOS are using these medications. And again, I'm still trying to formulate my thoughts on it because it's really new to all of us. I can tell you I do have concerns about, I have seen some people, in my opinion, develop anorexia on these medications, meaning just no appetite at all. And that's a problem because food is not optional. So it's always something someone, in my opinion, should go into with eyes wide open that you still have to eat. And so working with your clinician to make sure whatever dosing you're getting is helping you lose weight without wiping your appetite out too much, I think is important. The only kind of fasting that I think has any staying power is extended time fasting. Insulin sensitivity does follow a circadian curve, and that it rises in the early hours of the morning and fades and as the sun goes down and it gets dark. So in anyone with insulin resistance, I think it's important to get up and kind of get going with your eating during the daylight. So I'm not a fan of 8-16 fasting, particularly that encourages people to skip breakfast, because then that's skipping eating at the time of day when your insulin sensitivity is higher. But I do think it's a good idea for people to eat enough during the day that hopefully, for the most part, we can have dinner and then, go relax without continuing to eat a lot into the evening, in part because of this effect on insulin sensitivity. Okay, I'm just going to go through these real quick because we basically are out of time. All fruits and vegetables are good for fertility and good for PCOS. Fruit is good for insulin resistance. People who eat whole fruit have less diabetes. Drinking a lot of juice may increase your risk of diabetes, so whole fruit is nothing but good. Just spread it out over the day. Do diet improvements help egg quality for women with PCOS? Yes, they do. Does being overweight with endometriosis make it difficult to have a successful IVF cycle? It depends on weight in and of itself, either too high or too low, can affect fertility, regardless of what's going on with somebody's endometriosis. So it's possible for people to have challenges on both fronts. Not a ton of research on endometriosis and diet, but the stuff that does exist that I've seen is in favor of an anti-inflammatory type diet, like I've been alluding to. Protein shakes, yeah, particularly if they're made with good ingredients. I prefer, if something's going to be a protein shake, should be made with as many whole foods as possible. I can't tell you if PCOS increases the chances of a chemical pregnancy. I know it's recommended that people that it takes at least a couple months on inositols to start to see some benefits on insulin sensitivity. Reproductive endocrinologists are in a great position to diagnose PCOS. Yes, you can have PCOS and have regular periods that aren't productive. Berberine does have some potential benefit as an insulin sensitizer. I don't tend to use it because my patients are actively trying to conceive, and we don't have enough safety data on that. Again, I don't believe in anything that can't be sustained. So intermittent fasting, that like 8-16, I've just seen too many people lose and then realize they can't live their life forever only eating through an 8-hour period. Yes, you can conceive naturally with PCOS. Theralogics has some male fertility supplements if you want to look at their website. Yes, my understanding is somebody has diabetes, a low sperm count, they will likely need some, fertility intervention, but yes, you can get pregnant. Folic acid, if you're actively trying to conceive, at least 800 milligrams is a good amount. Is my nutrition consult only provided in Massachusetts office? I currently see yeah, I am only able to see patients now in Massachusetts and New Hampshire because of my license. All right. Yeah, Ozempic, I don't think you can take those drugs while you're actively trying to conceive. Carnivore diet, if it's too high in meat and too low in fruits and vegetables, not a fan. All right. Thank you very much, everybody, for attending. I really appreciate it. Nice of you to all be here. One last question, because I think it's an important one. Would limiting gluten help to treat PCOS? Only if you have celiac disease. There is not science telling us that women with PCOS are more likely to have celiac disease than anyone else. People can have gluten sensitivity because they don't feel good if they eat gluten-containing things, but it's always important to keep in mind when people follow gluten-free diet, they often take a lot of junk food out of their diet, which in and of itself is going to make them feel better. All right, and yes, Ovasitol is very helpful for people with PCOS. Thanks for showing up. Have a good evening.